This is an out-of-tune ukulele. But we ain't talking about that today. Welcome to musculoskeletal disorders. When your patients have back pain, man, there is a lot of stuff that could be causing the back pain. So, how do you figure it all out? Well, the basic pathology of back pain, as you can imagine, depends on what's causing the back pain. So this is one of those cases where you're asking questions, you're playing the detective, trying to get at what might be going on in this person's back. Specifically, where is the back pain? What activities bring it on? Are there certain movements in one direction or the other that either exacerbate the pain or help it go away? Are there medications that are specifically helpful? Are there medications that are ineffective? Back pain is one of those nursing type of things that you guys in primary care are going to see over and over and over again, and asking the right questions is critical to help you figure out what's going on. So, maybe your patient has degenerative disc disease. Maybe your patient, if they have a history of cancer, God forbid, has metastatic disease to the spine. Maybe your patient has osteoporosis, loss of bone integrity along vertebra within the spine. Careful questioning can help you figure out what's more likely and what's less likely. One thing you'll definitely want to ask your patients when you're talking to them about back pain is the quality or character of the back pain. And one of the big differentiations that you're going to look for is if the back pain is very specific to a spot or if it has this kind of shooting, lightning type of quality. Clinically, you might hear people use the term radiculopathy, a very common term to describe that kind of pinched nerve sensation where the source of the pain impinges on a nerve and then patients feel this shooting pain down a certain nerve distribution area. The most common of that is sciatica. Whenever I mention back pain and primary care, I always present this particular scenario only because I've seen it about 100 times or more. Somebody with a history of a common cancer, such as lung cancer, or breast cancer, or prostate cancer, a cancer that we as clinicians know commonly spreads to the bone, comes into the primary care clinic and says, "Hey, I have new back pain." And in the clinic, things are busy, you're moving around, and maybe this patient was treated for their cancer 1, maybe 2 years ago, and they've been declared cancer-free, woo, which is great. That's awesome. But in someone with a history of a cancer that we know likes to metastasize to the bone, breast cancer, lung cancer, prostate cancer, that patient comes in with new complaints of back pain, or for that matter, bone-style pain anywhere else in the body, be suspicious for new areas of cancer metastasis. Musculoskeletal lectures are always full of terminology, kind of a vocabulary kind of thing. So here you see 3 terms: bursitis, tendinitis, and impingement syndrome. They're not really that hard. Bursitis, inflammation of the bursa. Tendinitis, inflammation of tendon. Impingement syndrome, something specific to the shoulders, whereby people who do a lot of repetitive upward pushing, think people that are painting, working above their heads and whatnot, over time gradually squeeze the area at the superior aspect of the shoulder joint, and that impingement can cause pain. Impingement syndrome and rotator cuff specific pathology are technically separate, but sometimes you may hear them used interchangeably. Impingement syndrome can be a precursor to true rotator cuff injury. Risk factors for these would probably be those things that you could imagine yourself. Things such as use, disuse, wear and tear, overwear and tear, occupational injury, age-related changes. Probably the most classic repetitive motion injury that I think just about everybody's familiar with is carpal tunnel syndrome. Impingement of the median nerve in the arm, oftentimes due to an occupation-based repetitive movement. Much like many things in the clinical setting, if you're suspicious of carpal tunnel going on, what you'll actually do is try to actually inflict or cause that pain on your patient within the clinical setting to help verify what's actually going on. In this particular case, you'll have Tinel's or Phelan sign, in which you move the hands in those two directions there to try to actually cause the pain that the patient tells you that they have outside the clinic. Please note that the pathology involved in carpal tunnel syndrome can be more than just the median nerve itself. So there could be cysts growing in them. There could be problems with the bones in the area. There's other things that could be going on causing impingement of that median nerve. It doesn't have to be necessarily just the nerve itself. Thankfully, CTS can be relatively easily treated in most people using a variety of either braces. There are surgical options. Sometimes just avoidance of the activity is all that's necessary. No talk on musculoskeletal disorders and carpal tunnel syndrome in particular would be complete without going to the other side of the hand and talking about pathologic degeneration of structures within the hand causing cysts, ganglionic cysts or ganglions by themselves. And these just tend to be fluid-filled cysts that occur after the loss of periarticular surfaces that would otherwise help cushion the movement of the hands that we have. Much like carpal tunnel syndrome, ganglionic cysts are often found in people who have repetitive motion, occupations that involve very repetitive tasks that are in some way destructive to the joints. Now, does everybody who has that occupation get carpal tunnel syndrome or ganglionic cysts? No, so we know that there's probably an inherited predisposition to the development of CTS or ganglionic cysts as well. And you've got to keep that in mind when you're thinking about these patients. Hey, why doesn't everybody who's a court typist get a repetitive motion injury? Again, probably inherited susceptibility to that disorder. So Dupuytren's disease or Dupuytren's contracture is a very specific thing with regard to the hand and fibroblast proliferation. Why fibroblast proliferation? Well, we think it has something to do with the Wnt cell signaling pathway for growth and development within those fibroblasts. But just like everything else in the world, there are probably certain environmental insults that also have to occur for that cell signaling pathway to then start kicking into high gear and causing the fibroblasts to proliferate. There is your risk factors for this particular thing. So as you can see from this particular picture, gradually over the course of time from the fibroblasts, basically the fibroblasts start to pull the hand inward, slowly, and patients will come into the clinic and say, hey, I can't straighten my hand out. Very easy to figure this one out. Do you like to run? I like to run. Well, I used to like to run, but now I weigh a lot more than I used to. Anyways, one time a long time ago, I woke up with this massive pain in my plantar fascia. It was textbook, right where the plantar fascia meets the calcaneus. Oh, it hurts so bad. Very bad in the morning after I'd been sleeping. Took a while to stretch it out. Ooh, so much pain. Thankfully, orthotics worked for me. Plantar fasciitis is no fun, but thankfully, in those people that have it, it's relatively easy to correct in most cases. For a lot of these repetitive motion injuries, Things like splints and avoidance of whatever the activity is that exacerbates things is all that's necessary. These are things in which surgery would be the last option, not one of the first options. Whenever I'm mentioning ACL trauma, the first thing I always say to people is don't confuse the anterior cruciate ligaments with the Achilles tendon, and sometimes that does happen. So these are two different injuries in two different parts of the leg. One is in the knee, one is down by the foot. ACL trauma. This is that common thing that you see in basketball players when they're running, they're jumping, and then they just come down in the wrong way and pop! Ooh! And yes, pain, pain, pain. A lot of ACL trauma occurs in athletes. And in addition to damage to the ligament itself, people can also sustain damage to the meniscus, which is the cartilage lining within the knee joint. When I talk about ACL trauma, I always try to make sure I'm distinguishing it between ACL and Achilles. When I talk about TMJ, I try to make sure that people don't confuse it with trigeminal neuralgia, which can produce clinical presentation that is similar. However, technically they're different in terms of their pathologic origin. So in trigeminal neuralgia, the nerve is the root of the problem. In TMJ, the musculoskeletal area where the jawbone then meets the skull, the temporomandibular joint, is the source of the problem. Though the pain, the swelling, and the influence on the trigeminal nerve and its distribution can mimic what is found in trigeminal neuralgia. Just like all the repetitive motion injury pathologies, avoidance of whatever is exacerbating things, maybe some type of device worn while sleeping. You have to do a thorough history to figure out what's going on that's causing the TMJ, and then therapeutic options can be looked at beyond there. Finally, something that's not a repetitive motion injury. Oh, thank you. Oh, wait. Bunions. Ah, bunions. Ah, bunions. They taste great on salad. Hallux valgus or bunions are everywhere. Who doesn't have them by a certain age? They are actual bone enlargement, usually due to poor fitting shoes or something of that nature. They are typically not intervened upon unless they're causing a fairly high degree of pain or discomfort or something like that. So this slide is here mostly to introduce you to the proper term for bunions, and that is hallux valgus. Morton's neuromas are kind of interesting because the typical kind of process by which these occur is that the person sustains some other musculoskeletal injury, and in the process of healing develops a kind of neural or neuron-based mass, a Morton's neuroma. And because this is a mass of neurons, ooh, it's tender. You'll probably notice in your reading that a lot of these pathologies your book does not go into great detail on. It's a couple paragraphs, that's about it, kind of know what it is. Osteoporosis is one of the exceptions. Part of that is just because of its impact on society. Osteoporosis is a massively common pathology of old age and of nutrition, but not only that, the weight upon which osteoporosis bears cost to the healthcare system and to medical care and things of that nature, that and the complications that can result from osteoporosis do produce its massive impact on society. So osteoporosis, the definition, if you can't guess from the name, gradual loss of bone. Osteoporosis, the name kind of says it all. Porous bone. What's going on? gotta go back to your calcium homeostasis in the body to really understand the term negative calcium balance. You also got to remember from A&P that the skeleton is the major repository for calcium in the body. So if calcium is not properly stored within the bones, bone density loss will occur. If there's an increased need for potassium within the blood, bone density loss can occur. In addition to that, if improper nutrition occurs, think about calcium and vitamin D intake. Remember the parathyroid. What's the parathyroid's job? To maintain calcium homeostasis. Calcium homeostasis in the blood is very important because your heart uses calcium to beat. And your body sees your heart as more important than your bones. So if it needs more calcium, it will take calcium from the bones if you are not taking in enough orally. What will happen is the parathyroids on the back of the thyroid gland will say, hey, calcium level's low, crank out parathyroid hormone. That parathyroid hormone will suck calcium and phosphate out of the bones to save the integrity of the heart's electrical functioning. I put the term DEXA scan here as a medical term for you to start adding into your medical testing vocabulary. DEXA scans measure bone density, and they give out a score, and the score helps the clinical team decide what kind of treatment patients with osteoporosis should be given, because patients with significant osteoporosis are at risk for all kinds of things, probably most importantly, traumatic or pathologic or both fractures. Now, treatment for osteoporosis could be something as easy as calcium and vitamin D supplementation. However, in a number of individuals, and you will see these in clinic, that's not going to be enough. So there is a whole slew of prescription strength medications that are delivered through various means to re-regulate calcium balance in favor of putting more calcium phosphate into bones. And if you watch any television show that has commercials, do any television shows have commercials anymore? I was going to say the commercials for, on older people shows like Jeopardy, they'll be selling a drug for osteoporosis. Go talk to your doctor about blah, 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 blah. Packett's disease is, I think, very interesting. We know it has a genetic component. We know that osteoclasts demonstrate this phenotypic change that increases their activity, yet we don't specifically know why it's in some areas of the body and not others. We don't quite understand why the clinical presentation is different in different people with technically the same disease. There's still a lot left to study here. There are differences in the inherited forms versus the sporadic forms. Patients who encounter those genetic changes through mutations over the course of their lifetime as opposed to something inherited from their family. But we're talking about a lot of little bone and bone diseases today. Why don't we talk about bone infection? Osteomyelitis, infection of the bone, and sometimes the bone marrow, the center part of the bone as well. Now, first thing you should think of is, isn't a bone kind of sterile? Yes, you would be right. So, how does an infection get into the bone in the first place? Well, one of the ways is via the bloodstream. So people who have bacteremia and or sepsis can deposit microorganisms, infectious microorganisms. Another way could be through direct trauma to a particular bone as well. Let me give you a clinical picture that I have seen over and over again in my career. A diabetic gets a foot ulcer. Because of the loss of nerves through their diabetes, they don't feel the ulcer. It's on the bottom of the feet, and the ulcer gets bigger and bigger and bigger. Staph, maybe some other microorganisms get into the ulcer. The person never feels it. The ulcer gets deeper and deeper, finally gets into the calcaneus. So we have the potential for calcaneus or calcaneal osteomyelitis by virtue of a person having diabetes and then having what would be a small foot infection, untreated, gradually grow into a soft tissue infection, gradually grow into osteomyelitis. So things like diabetes are considered a risk factor for the development of bone infection. In addition to that, if people have really messed up arteries, for example, peripheral arterial disease, that too is a risk factor for the development of osteomyelitis because there isn't good delivery of blood and therefore white blood cells and therefore defense mechanisms to areas of injury to stop or thwart infectious processes. Now, treating osteomyelitis is hard. The diagnostic workup will definitely include blood cultures and sometimes even wound cultures, if they're accessible, to try to figure out what microorganisms may be causing the infection. Here's the thing, they're not often positive. Therefore, these patients may be treated on many different antibiotics to try to find ones that will help clear out the infection. In addition to that, because of the relatively poor vascularity of the area, antibiotic treatment needs to be prolonged more often than not to obtain a good result. Osteomyelitis that is not treated medically successfully with antibiotics may need to be treated surgically with amputation. And I mean amputation higher than the point of the osteomyelitis. So take a patient that has osteomyelitis of the right great toe. They may need to get amputation of half the foot or amputation at the level of the ankle to obtain an infection-free limb. Take someone with severe osteomyelitis at the calcaneus going up into the ankle. They may need a mid-tibial or below-the-knee amputation developed depending on the severity of the soft tissue infection as well to obtain a successful infection-free outcome. The basic pathology for septic arthritis is fairly straightforward. I didn't even bother typing it out. You have arthritis, which is inflammation of a joint, and then you have sepsis, which is indicative of an infection of some type. Septic arthritis is most commonly bacterial in origin. The bacteria typically seed into the joint from the bloodstream, though this can be a post-operative thing too. People have arthroplasty or joint surgery, which is normally sterile, but can you guarantee it's sterile 100% of the time? No. And then after the surgery, a septic arthritic picture develops. So either via blood or via direct access to the joint, some microorganisms get into the joint and set up a septic arthritis clinical picture. Typically, patients who develop septic arthritis have some type of risk factors kind of predisposing them to that potential, such as advanced age, other comorbid states that make them already sick to begin with, and create an environment whereby that person's immune system isn't able to keep things in check, allowing bacteria free range in the body, and they find areas that are nice and sterile to go proliferate in, such as a joint. Okay, I'll be honest right now, I could probably give a 3-hour lecture all about bone tumors, primary bone cancer. They're fascinating, but it's not really the focus of this class. So we're going to kind of go a little more superficial here. The first thing I always say when I talk about bone tumors is to make sure as a clinician that you distinguish primary from secondary bone tumors. Here's what I mean. Secondary bone tumors are metastases from other primary sites. A lung cancer that spread to the bone is a secondary bone tumor. Breast cancer spread to the bone. Prostate cancer spread to the bone. I make the same distinction when I talk to my students about brain cancer. Most brain cancer is a metastatic site from a primary cancer elsewhere in the body. Likewise, most bone tumors are metastatic sites secondary to a cancer in another part of the body. Primary bone tumors and bone cancer is actually relatively rare. Because of the relative rarity, the research on primary bone cancers is nowhere near as voluminous as breast cancer, prostate cancer, lung cancer, things of that nature. Nevertheless, the basic pathologic features that define all tumors and cancer growth and whatnot still apply, because even our cartilage, our bone are still, all those cells are still a balance of oncogenes and tumor suppressor genes. So here I give you an example of two common tumor suppressor genes that are known to be inactivated in many osteosarcomas. The other thing I do here is kind of give you a little bit of a terminology talk with regards to cancer in general, but I'm using bone tumors as a way to illustrate a point. If you look at the column of terms under the benign heading and then look at the column of terms under the malignant heading, I try to break down how the terms differentiate tumors that are benign versus differentiating tumors that are malignant. So under benign, we've got osteochondroma, osteocon and oma, bone cartilage mass. Osteoclastoma. Osteoclast is your cell, oma means mass. If we add in the term sarcoma, a sarcoma by definition is a malignant mass, aka a cancer, of connective tissue origin. So therefore, an osteosarcoma is a bone mass, a bone-based connective tissue mass that is malignant in its potential. It is a cancer. A benign tumor is not.